Welcome, Dr. Poston, to the Parkinson Support Group of Sonoma County. Dr. Kathleen Poston is Chief of Movement Disorders Division in the Department of Neurology and Neurological Sciences at Stanford University. And she will talk with us today about mind and memory in Parkinson's today.
Thank you all so much for having me and spending your Saturday afternoon here with us all. I think this is a wonderful group. I wish I could be up there in person in Sonoma, but here we are today, and perhaps in the future you all can have me come up in person and give a talk. My husband and I love going up north. So today I'm going to be talking to you all about mind and memory, or cognition, in Parkinson's disease and Lewy body dementia, and just to sort of give a good sense of what it is that we think about with regards to cognition, mind, and memory, and why we need to think about it, and why it's so difficult to understand within the context of Parkinson's disease. So first of all, this is our now very large Stanford Movement Disorder Center. I've been there since 2009. We have a group of 8 adult movement disorder specialists, 2 pediatric movement disorder specialists, and 2 neurosurgeons. All of us who have different focuses. But, you know, I sometimes call myself a non-motor movement disorder specialist. And, you know, one of the questions that I often get asked is, why does someone whose literally title is defined by movement disorders care about these non-motor things like cognition? Like, where does this dichotomy come from? And in fact, if you go all the way back to the original essay on the shaking palsy by James Parkinson in 1817, he talked quite beautifully about all the different movements that he observed in the 6 or 7 patients. By the way, that's all he wrote about in this description, some of whom he only saw walking down the streets of London, didn't even do a formal neurological exam on, where he talks about the tremulous movement, lessened muscle power, propensity to bend forward at the trunk. But at the end of the first paragraph, in fact, I made a comment about the senses and intellects being uninjured, and really defined this as a movement primary disorder. Well, it turns out that idea that Parkinson's disease was really primarily about the movement was a major paradigm that doctors were taught for many centuries, actually. And it's really not until the last 30 or 40 years that people started to pay more and more attention to the non-motor aspects of Parkinson's disease. And really in the last 10 years, it's come to the point where we as movement disorder specialists independently assess the motor symptoms of Parkinson's disease and the non-motor symptoms of Parkinson's disease. I'm going to talk a little bit about that for a moment here. So what do I mean by the non-motor symptoms of Parkinson's disease? Well, it turns out there are a lot of potential, but not all of them happen in all patients. The timing in which some of these non-motor symptoms happens also varies dramatically by the phase of the disease. So there is a bunch of these non-motor symptoms that actually can precede or happen before the very first motor symptom. So before the very first shake, before any movement is slow or stiff or walking changes, patients can report a loss of sense of smell. They can report constipation. They can report sleeping problems, which we call REM sleep behavior disorder, which is when patients act out their dreams. They can have other insomnia problems. There are sexual problems that can occur very early. There's some pain syndromes that have been described. Hypophonia is that softening of the voice that in retrospect, a lot of patients talk about, and all of these can happen before the very first motor symptom. So it's not like Parkinson's disease always starts with a motor symptom. It actually can start with a non-motor symptom. So then there are different things that can happen early-ish, but not always. And so those are things like some mild to moderate memory problems, depression or lack of interest in activities like apathy. Patients can experience sometimes some anxiety. There's some what we call autonomic dysfunction, and those are things like urinary urgency, excessive sweating, salivation. So those are all parts of the autonomic nervous system, which is the part of the nervous system that controls things like your sweating and urination and blood pressure, those kinds of things. Dysarthria is that slightly slurred speech that some patients can experience. Dysphagia is some difficulties with swallowing. And then sometimes, not in everybody, but sometimes later in the disease, there can be worsening of these non-motor symptoms where patients can actually experience dementia, which I will formally define in a few minutes. Hallucinations can occur, severe orthostatic hypotension. So that's when the blood drops dramatically when people stand up. The orthostatic is going from sitting or laying to standing, and hypotension, low blood pressure, which can cause people to pass out. Urinary incontinence can occur, and more severe swallowing and choking episodes. So this is kind of a broad range of non-motor symptoms. But again, the key thing is that not all of these things happen to all patients. And that's one of the reasons why it's so hard to study. So again, nowadays we think about these a lot more, but the motor symptoms were just simply more obvious to doctors, right? I can see the tremor, I can feel the stiffness, I can measure the slowness. Those are very observable things that we can see on an exam. Whereas I have to ask somebody if they had insomnia last night. I have to ask somebody if they're having constipation. And so it requires a lot more questions and a lot more dialogue with the patient to get at the non-motor symptoms. I can't just simply do an exam and understand whether somebody has experienced one of these non-motor symptoms. And because of that, the impact on these non-motor symptoms for a long time wasn't really recognized. Now that we have some really high quality research studies that have followed groups of Parkinson's patients every year for 15, 20, 25 years that have really assessed these things, now we actually have a good idea on how they actually impact quality of life. And so it's really, again, in the last couple decades that this has been obvious. The other big barrier to understanding the non-motor symptoms is that there's much more variability to the type and severity of non-motor symptoms that are experienced from patient to patient. And because of that variability, studying this is harder. So if I were going to start a research study and I wanted to enroll patients who had slowness of movement within the context of Parkinson's disease, every single patient who comes to my clinic could enroll in my study because every single patient has some element of slowness to their movement. But if I was to do a research study and I wanted to study, let's say, that REM sleep behavior disorder, well, not every patient has that, only a subset do. And so it's harder to find the specific patients who have those specific non-motor symptoms. So they're just simply harder to do from a practical perspective to understand from research. And so that's another reason why we don't understand this quite as well as we understand the slowness and stiffness. And what we'll get to at the end is that, unfortunately, understanding something is the first step to treating it. You can't treat something that you don't understand. And so part of the reason we don't have as many treatments for some of these non-motor symptoms is in part because we haven't understood them well enough. So, if you don't understand what the problem is, it's very hard to come up with a super useful solution. Okay, so why is it important to treat them when we can? Well, it turns out the impact of quality of life in many instances can actually be greater than the motor symptoms. So I think we've all know what it's like to have a terrible night's sleep. Well, I'm sure some of you have experienced pretty bad sleep problems in the context of Parkinson's on a regular basis. And that has a huge, huge impact on quality of life. I know how miserable I feel when I just have one bad night of sleep, but to have that chronically throughout the course of the disease can really impact quality of life. The other really important reason to understand this is that it turns out your brain and your body are all connected. And anything that worsens your non-motor symptoms can actually worsen your motor symptoms. So let me give you an example of that. So tremor can actually get much worse when you're constipated. We see this all the time in patients, or if patients have a really bad night's sleep, or if they're really anxious, their memory can be much worse. And this is in part because, you know, again, the brain and the body are very connected, and the stress that's put on your body and also on your brain when you have a stress like constipation, or you have a stress like not having much sleep, it's going to enhance other things that are going on. And so it's not common when there's other problems happening that tremor worsens or memory worsens. And so these things are all very, very interrelated to each other. And so sometimes, you know, the best way to treat a motor symptom is to address an underlying untreated non-motor symptom. So they're not independent things. They're very interconnected with each other. We see this all the time in clinic, where there's one thing that gets worse, and that sometimes causes a cascade of 2 or 3 other things that kind of get worse along with it. And finding the symptom that's kind of the root cause of the problem is oftentimes the best approach to having things improve, because that will fix all of them if we can come up with a solution for it. So how do you talk to your doctor about these non-motor symptoms? Well, again, you have to tell your doctor, or your doctor needs to ask, but even if they don't ask, you should tell them anyway, because they can't do an exam to necessarily get at these things. And so one way to think about your non-motor symptoms is to think about them in terms of a diary, because they don't always happen, and they're not necessarily happening at the moment that you're in the clinic visit. And so the doctor's not going to see it. They're not going to see you experiencing it. And so they're not going to know about it and let you tell them about it. So one of the reasons why diaries work is because it helps us to understand the relationship between the non-motor symptoms and some of the motor elements. And as you all know, dopamine is the best treatment for many of the motor symptoms. But the relationship between dopamine and the non-motor symptoms is complicated. There are some non-motor symptoms that get better with dopamine. There are some non-motor symptoms that get worse with dopamine. And there are some non-motor symptoms that have no relationship whatsoever to dopamine. It doesn't matter what you're doing with your dopamine, they're going to do their own thing. So how the heck do you figure that out? I personally find that doing diaries is a good way to look at it. So let's say this is your typical day. You're taking one pill of 25-100 Cinemet 3 times a day, and you notice that you have some symptom that tends to start about an hour before you take your second pill of the day, and it tends to go away about 30 minutes afterwards. Well, this potentially is a non-motor symptom that might be actually getting better when you take the dopamine. It tends to arise when one dose is wearing off, and it goes away shortly after you take a medication. So that's kind of one situation. This one is a non-motor symptom that improves. This would be an example of a non-motor symptom that worsens with dopamine. So what's a non-motor symptom that every time you take your medication for about 30 to 45 minutes afterwards, that non-motor symptom actually gets a little bit worse. And so an example of something like that might be sleepiness. There are some patients who get a little bit fatigued or a little bit sleepy during the hour after they take their medication. So that's one that potentially could get worse. And then here's a non-motor symptom that seems completely independent of the dopamine. So it seems to happen after you take the medication in the morning, but then kind of appears in the afternoon before somebody takes it. Well, this one has nothing to do with the medication, but actually is related more to meals and might happen after somebody eats breakfast and then after they eat lunch. And a common one here is low blood pressure. So it turns out after you eat, your blood gets diverted to your stomach and away from your brain, and actually can cause your blood pressure to drop a little bit. This actually has a medical term called postprandial hypotension. So after eating hypotension. It's actually that reason why when you were a kid, people told you not to swim for 30 minutes after you eat, is because the blood gets diverted away from the muscles, and kids would cramp in their muscles after they would eat because they wouldn't get enough blood flow. And if you cramp when you're swimming, you can drown. And so that's the whole reason behind the kind of silly myth of don't swim for 30 minutes after you eat. It's because of this, because the blood gets diverted away from your muscles and to your GI tract for the 30 minutes after you eat. If you have Parkinson's though, and you have low blood pressure, this actually drops your blood pressure even more, and it can cause you. And so this is one where the dopamine has nothing to do with it. It's another cause. So these are just good ways of trying to figure out the relationship between certain non-motor symptoms and your medications and other things that you do from day to day. Okay, so we're going to focus the rest of this talk on the mind and memory element of the non-motor symptoms. Things that I term mild to moderate memory problems, and then also we'll touch a little bit on dementia and understand a little bit more about what that is. So before I start there, there's something that comes up all the time, and this has to do with terminology with regards to cognition and dementia, and that is the relationship between Parkinson's disease and this closely related dementia with Lewy bodies. So it turns out we as doctors over the last decade would give something a name based on how the patients presented to us clinically, because we didn't have the capacity to really look at MRI scans or other biological markers to understand things. This is sort of the way that diseases were named during most of the 1900s. And so there are these two separate clinical terms that are used, and it has to do with whether somebody starts off with those motor symptoms of bradykinesia, which is slowness in movement, rigidity in the muscles, and tremor. If someone starts with those first, before they have bad cognitive problems, we call that Parkinson's disease. If somebody's cognition starts out particularly more affected before any of the motor symptoms start, that got termed something else, either Lewy body dementia or dementia with Lewy bodies. And it's an artificial distinction. And officially in the literature, there's a 1-year rule that if really bad cognitive symptoms happen a year or more before the motor symptoms, we officially call it Lewy body dementia. If the motor symptoms started before or within a year of the cognitive symptoms, we call it Parkinson's disease cognitive impairment. It's an arbitrary line in the sand, and it helps us as researchers to talk about things, but it's not very helpful for patients and families because they get a lot of mixed messages of, oh, is this Parkinson's or Lewy body dementia? And it turns out they're not actually different diseases. It's just a spectrum, and we're just naming it different things because of our lack of understanding. When patients pass away, that's the 1-year rule we use. When patients pass away and they donate their brain to research, the brain of somebody who has Parkinson's disease versus Lewy body dementia look identical. They both have these Lewy bodies. This is a pathology slide. This is a neuron. And this pink thing right here is a Lewy body that the German physician who first identified them, Dr. Lewy, it's actually German, so it's with a V, but I don't pronounce it correctly, that originally identified. This is a high, very, very high microscopic view. And then the staining here this is a slice through the front part of the brain, and the staining here shows the regions of the brain that have these Lewy bodies in them throughout the cortical ribbon. The brain looks identical. So biologically, Parkinson's disease and dementia with Lewy bodies probably are more the same thing, and one of them just affects the motor symptoms more, and one affects the cognitive parts of the brain more. It's about real estate. It's about where the Lewy bodies are. It's not differences in the Lewy bodies, right? So if you're the house that's literally right on the ocean, you're an oceanfront house. If you're anywhere else, you're not. It's all about location, right? Same thing with the brain. If you have Lewy bodies in the part of the brain that control the motor things, you have motor symptoms. If you have Lewy bodies more in the part of the brain that control cognitive stuff, you have dementia with Lewy bodies. And we do not currently have a brain scan that we can do in living patients that can identify the Lewy bodies in the brain. Lots of research going into that. So we can't identify this until after people pass away. So we use our clinical terms. So that's just to clarify a bunch of misunderstandings that I get a lot about diagnoses. And so the term we use is Parkinson's disease. And if someone has cognitive impairment or dementia, we say Parkinson's with cognitive impairment or dementia. whenever the motor symptoms happened first. If the cognitive impairment and dementia happened first or within 1 year, we call it the dementia with Lewy bodies or Lewy body dementia. Sometimes people just use a generic term called Lewy body disease, which technically includes both of them. Basically means any of the neurodegenerative diseases that involve Lewy bodies. So people have started using that generic term. To be honest, as soon as we do finally be able to identify Lewy bodies consistently and successfully in living patients, my guess is this terminology is probably going to change and become a more unifying terminology, but not until we have a good marker for Lewy bodies that's very reliable in living humans. We're almost there. I actually think we're going to have one in the next couple of years. Okay, so time to redefine it. This is very common. The cancer field has done this numerous times, where they used to call things different types of cancers based on where they were located. And then once they identified a unifying gene or a unifying molecule, they've changed the names. I think you guys have probably noticed this in a bunch of those cancer commercials where they're like, you know, if you have non-small cell, and then they rattle off a bunch of letters. That's how they actually identify a lot of cancers these days, are based on the molecular signature, not on the location. And so as we move more toward that in neurology, my guess is that the definitions will follow that kind of nomenclature. Again, not quite there yet. Okay, so regardless of whether you have classic Parkinson's disease, or if your doctor has said, you know, this might be Lewy body dementia, the types of mind and memory changes are actually very similar. It's just when they occur. So what do we see? There are these 5 domains of cognition that we think about. Now, these are not truly independent, separate domains of cognition. They actually rely on one another quite well. But it's helpful for us to think about things in these terms, because some people have strengths in some and weaknesses in others, and some are more susceptible to impairment in people with Lewy body diseases, and others are interestingly more susceptible to impairment in people with something like Alzheimer's dementia. So let's talk about these different domains and what these actually mean in the context of Parkinson's. So the one I'm going to start with is executive function, and that's because this seems to be the one that is most commonly seen in Lewy body diseases, Parkinson's disease and dementia with Lewy bodies. It's also one of the harder ones to wrap your head around. So the official name, the official definition of executive function is cognitive processes that dictate a flexible and dynamic adjustment of performance in response to a changing environment. So an example of this is planning and organizing. You wake up in the morning and you find out, oh gosh, I have to go do these 3 things before I make my 1 o'clock meeting. How am I going to fit those in? You know, how am I going to plan and organize around this new information that, you know, I'm having people over for dinner tonight and I've got to go to the grocery store, but I have to do that before, you know, my meeting. So that's executive function. Novel problem solving. Something totally new gets thrown in front of you. Can you decipher it, and can you problem solve on it? Can you get that brand new, you know, change to your cable box, and you have a brand new remote, and you got to figure out which of the new buttons to press? Because in the old one, it was like the top left and the top right that turned it on, but now there's just one button. And how the heck do you get to all your saved shows? That's novel problem solving. That's executive function. We've all gone through that one before. It's shifting your attention. This is one that I have to deal with a lot. So you're sitting there trying to do some work, and you get a text from work saying that something needs to happen. You attend to that, you focus on that, and then can you go back to the thing you were first focusing on, reorient yourself and get yourself back on that? Can you be focused on this, redirect your attention, and then refocus back to where you are? That is executive function. And that comes into play with multitasking. Can you actually hold 2 or 3 or more tasks in your head at the exact same time and move forward on all of them? So this is the one that seems to be the hardest hit in Parkinson's. And a lot of my patients tell me that they notice that they start to have some problems, particularly with the multitasking and the attention shifting. I start doing something else and I completely lose focus and I'm not able to go back to what I was doing before. I used to be able to juggle 4 or 5 things at once and I just can't handle it anymore. If it's more than 2, it really breaks down. Family members will tell me, you know, we're fine as long as we've got the schedule, but if there are major changes in the schedule and we have to rearrange things, it can just be tough. That is all executive function. What I tell people is that this is actually one that you can make some lifestyle adjustments to. It's just hard in our current society. So we are very used to doing more than one thing at the same time. You know, we're watching TV and eating and talking and checking our phones all at the same time. Get rid of 2 of those. You know, if you're eating and talking, but you're not doing anything else. You don't have the TV on as well. If you're working on something, you know, make sure other distractions are gone. Finish one task to its completion before you give your loved one the next task that you want them to give. Don't give them the 5 things they need to get done on a Saturday and then wonder why none of them happen. Just give them one thing. And when they get done with that, then you go to number 2. And so do things more one at a time and don't overly stress the executive function. It's hard to change behavior here because all of us are so just used to living in this you know, multi plane world where all these things are happening at once, but this can be super hard for people with Parkinson's. So just keep that in mind. Related to executive function is the idea of attention and working memory. This is also can be impacted by Parkinson's. So this is faster. This is sort of the quicker element than the executive function is more kind of the long game and the big picture planning. Attention and working memory is more the moment to moment. So a friend tells you the date of an event. You have to keep it in your head for the 30 seconds while you unlock your phone and open your calendar, but you're keeping that date in mind. And then while you're unlocking your phone, you're distracted by a reminder on your phone to pick up milk from the store. Can you still put the right date in your calendar? So can you stay focused well enough on something or keep it in your working memory well enough to get it down while you're being distracted by other things? And then you forget the date completely if you're like me. Once it's in your calendar, it's like, dude, it's gone from memory. Doesn't matter. I don't know anybody's phone number. I don't even know my home phone number. Like I don't hold numbers in my head. I put them in my phone and then I forget them forever. But for that brief moment that I'm getting my phone to the right place and I'm putting in the phone number, that's working memory. And then it's gone forever, never to be remembered again. And so that short intervals, this can be a little bit tough also in people with Parkinson's disease, that ability just to hold that information just long enough for you to manipulate it or do something with it and be actionable on it can be a little bit more difficult in folks with Parkinson's. The other one that we hear about sometimes is visual spatial function. So your visual spatial function is your ability to navigate your physical body through the space that you're in or to visually manipulate the world around you. So where we see this, so people with great visual spatial function are like the ones who can have all the suitcases and luggage strewn all over the driveway and like can imagine perfectly how all it's going to fit into the trunk on one try, right? That's someone with good visual spatial function. And all of us are kind of different in how good we are at this, just kind of at our baseline. But in Parkinson's, sometimes it can start to erode a little bit. And we sometimes hear this with people having problems with parking the car, clipping corners, some problems with directions in areas that aren't necessarily familiar to them. I see it more when patients' families tell me about, well, they start sitting in the chair and they're like 1.5 feet away. Like, why don't they walk all the way to the chair before they sit down? Or clipping a corner through a doorway when they're walking through it. And so again, it's that visual spatial navigation, figuring exactly where your body is in relation to other things around you. This can also have some impact on visual illusions, seeing things that aren't necessarily there. So seeing like a bag on the floor and thinking it's an animal, or seeing some string on the floor and thinking it's a snake. And so some visual illusions can happen within the realm of visual spatial function. It can also tie into patients who are more prone to fully formed hallucinations. And that's actually seeing a fully formed person or fully formed animal or something that's not actually there. That's kind of a more extreme version of visual spatial dysfunction where the brain actually sees things without any type of stimulus at all. So there's a wide range of visual spatial function that people can experience, and again, sometimes can be affected by Parkinson's. One of the tests we do for this is where we'll show somebody a picture like this and then give them these different distraction pictures and say which one of these contains the exact figure that you see at the top. And here you can see that this one has the correct angles, but the idea is that the rest of the picture distracts. You have to pull out the elements that match this compared to this one that has the straight angles, this one that has curved or the acute angles but in the wrong places, and this one that has a combination of straight and acute angles. And so this is one of the tests that we'll sometimes do to try to assess different people's visual spatial ability and how well they can manipulate shapes in their mind. So memory. I called this talk Mind and Memory, and I use the word cognition a lot. And the reason is because pure memory is actually not as commonly affected in Parkinson's disease as it is in Alzheimer's disease. There's a lot of overlap, and it's not a pure separation, but a primary pure memory problem is actually much more common in people who have Alzheimer's disease. So, but memory is complicated. And so let's say your loved one says, can you pick up some milk while you're at the store? And you go off to the store. There are 3 different phases to memory that are really important. There's the encoding phase, where you actually keep the idea of, where you actually register the fact that you need to pick up milk. Maintenance, so you keep it in there while you're driving to the store and while you're finding a parking spot and trying to figure out where the heck your mask is in the front seat of the car and all that kind of stuff. And then there's the retrieval, when you're actually in the store, in the dairy aisle, do you or do you not pick up the milk, right? So that's the retrieval end. These 3 elements are actually taken care of in different parts of the brain. So there's a part of the brain that encodes, a part of the brain that maintains, and a part of the brain that does retrieval. We've actually done some really interesting research studies on this, where we've had patients while in a brain scanner do different tasks where they have to encode, maintain, and retrieve. And there are different parts of the brain. And it turns out that the retrieval piece is the hardest one in Parkinson's, where the encoding is what seems to be most affected in Alzheimer's disease. So what we find in Parkinson's is that patients might, in that milk scenario, they might get to the store and completely forget. But when they walk through the dairy aisle and they're reminded, oh, of course, milk, right? It was in there and it was maintained. It's the spontaneous retrieval at the right time, at the right moment, that's the most challenging. That is different than the information never getting encoded. If the information never got encoded, when you got to the dairy aisle, and let's say you're with someone and they're like, oh, didn't dad want milk? Really? I don't remember anyone telling me that. I have no recollection that I was told to get milk. That's not encoding it. And that's more typically what we see in Alzheimer's disease, that the information literally never got encoded in the first place. Whereas in our Parkinson's patients, it oftentimes gets encoded, but they have a much harder time with the retrieval. And that's one of the reasons in Parkinson's and Lewy body, lists can be incredibly helpful or reminders, any kind of reminders, because the information actually does get in there. It's just a little harder to retrieve at the right moment, at the right time than before someone had Parkinson's. And so we test this in clinic, where we give people these horrible lists of words to remember. And then 5-10 minutes later, we ask them about the words. And sometimes they can't come up with any of them, but then we give them hints. One of them was a piece of clothing, and they're like, oh, right. It was a hat. or one of them was a mode of transportation. Oh, that's right, it was a boat, right? And so that's how we know it was in there, but you give them a little bit of a hint and they can figure it out. And we know it's in the retrieval phase, not the encoding phase. So another place where you can intervene if someone's struggling with this, by using reminders or using hints to try to help with that retrieval process. The last part is language, and this is the one that's actually the least affected in Parkinson's. And that's things like naming objects or naming people, tip of the tongue phenomenon. It turns out this one's actually most affected just by the normal aging process, which is not good news for all of us because we're all part of the normal aging process. But having trouble with names and having that tip of the tongue phenomenon, that's actually not specific to Parkinson's at all. That is part of the normal, healthy aging process that we all get a little bit worse with this as we get older, but not necessarily that much worse within the context of Parkinson's. So, can you name an object like a lawnmower? Okay, so what is dementia? I said earlier that I was going to define dementia for you. So dementia is simply, again, it's a clinical term, and it just means that somebody's level of cognitive performance has gotten bad enough that they can't do independent activities of daily living. So for instance, they can't pay bills correctly anymore. They get so lost when driving that it's not safe for them to drive. They can't do full grocery shopping or cook full meals because of the cognition, period. Lots of different things cause dementia. Alzheimer's causes dementia. Parkinson's disease can cause dementia. Dementia with Lewy bodies can cause dementia. Strokes can cause dementia. People can have a major stroke or a bunch of small strokes, and that can cause dementia. There are other forms of dementia like frontotemporal dementia, which is a much rarer form of dementia. Lots of things can cause cognition to worsen enough that someone can't perform their activities of daily living independently. Parkinson's is one of those. So when someone has dementia, it doesn't necessarily cause the cause of it. It just is a severity of someone's cognition, and it just means that they can't do those things independently anymore. So what can we do? What can be done to prevent or change or treat these cognitive changes? So I've got a couple things on here, a couple of potential interventions that we can do, and we'll go through them. I wish we had the silver bullet fix it pill. We're not quite there yet. There are a lot of clinical trials that are moving forward on this. I've been trying very hard for the last decade to convince many different pharmaceutical companies and other agencies to really focus on coming up with treatments, true treatments, but we have a couple of options. So the first one is to know what the problem is. So I gave you a bunch of examples of things that we can do in a clinical setting to understand specifically, is somebody's cognitive problems more executive? Is it more that memory retrieval? Is it more the attention? Is it more visual spatial? Understanding the type of mind or memory problem someone's experiencing really is the first step to treating it, because if you understand it, then you can at least make some steps to adapt to it, and it can become less frustrating. And one of the things I hear all the time is that patients are just frustrated because they just can't do it the way they used to. And I completely understand that frustration. There are sometimes some mild behavioral changes, though, that a patient or their family can do to adapt that make it less frustrating. And anything that makes our life less frustrating is worth trying. And so understanding the problem, to formally do that, we need something that's called neuropsychological testing. It takes like 1 to 2 hours. And it is basically can parse out, is the problem within what we would expect for your normal age? Is it worse than what we'd expect for your age? Is it more executive? Is it more memory? It can sort of tease those pieces out for those kinds of things. And so I find these to be very helpful for my patients to just understand more what the problem is. So the second thing is to treat other conditions. So this goes back to that idea that the brain and the body are tightly connected to one another. And it turns out there are a bunch of things that make cognition worse that have nothing to do with Parkinson's. So one of them is your medications. So there are some medications prescribed for Parkinson's disease that can make cognition worse. We've kind of gotten rid of using most of them, but it's always worth having your doctor look at your list of medications and make sure there isn't anything. One of the other culprits is that there are some medications that treat urinary urgency that can actually make memory and thinking a little bit worse. They do cross the blood-brain barrier. It's the older kind of medications. There are some newer ones that don't cross into the brain that are much better, but because they're newer, sometimes insurance doesn't cover them, so doctors use the older ones. So it's just always worth saying, hey, I'm a little worried about my memory. Can you just take a look through my list here and make sure nothing might be making it worse? Because you want to make sure you make that trade-off. If somebody's cognition suddenly gets worse, like really suddenly gets worse, like they were doing fine on Saturday and Sunday, and on Monday they're just confused, they can't organize anything, that's when I think about infection. So whenever something happens quickly, infection is number 1, 2, and 3 on the list. And urinary tract infection is the big one because you don't necessarily get a fever. And as we get older, you don't necessarily get pain with urination. Sometimes just being really off is the only thing that you get. And so if something suddenly changes, a visit to urgent care and making sure there's not a urinary tract infection, because that is 100% treatable with antibiotics. So you can absolutely treat that one, and you always want to make sure. So if something changes quickly, first thing to do is go to urgent care. Don't wait for your next neurology appointment 3.5 weeks from now. Go to urgent care now. Make sure it's not an infection. And obviously COVID is one of the big ones that we worry about these days as well, to make sure that that's not brewing. I've had a couple of patients who actually did get COVID, and one of the first things they did notice is that in addition to the fatigue, they didn't notice the loss of smell because they'd already lost their smell 10 years ago. They were feeling more fatigued and they just couldn't think very clearly. And that ended up being before they had the fever. And so just think infection when something suddenly changes, it's suddenly different. Some other things we look for is make sure thyroid is okay, B12 levels. Those are good things just for your primary care doctor to make sure they're checking on a regular basis. Depression can really impact cognition. It's hard. It's attention is one of those things that really gets impacted by depression. And so making sure if you're really feeling kind of blue and, you're just not feeling yourself emotionally, that's treated. And I have had a couple of patients who have gotten properly treated for depression and their cognition improved significantly. It actually was quite remarkable on formal testing. Has really improved. So this is one to make sure you pay attention to. Dehydration and blood pressure fluctuations. If you're not getting enough blood to your brain, there's no way it's functioning properly, right? So how the heck are you going to remember that list of words if you don't get any blood to your brain? So make sure you're hydrated, make sure your blood pressure is in a good range. This is another one that can have a big impact on cognition. Obstructive sleep apnea and insomnia, both. I know if I get a bad night's sleep, my brain, there are certain things I can't do. Like I can't write a grant or write a research paper if I don't sleep well. So my cognition is definitely impacted by sleep. And then hearing loss, is part of it that you're not hearing everything people are saying. So a good audiology exam, whenever you start to see some problems with cognition, this is an important one. So these are all things that can, again, secondarily impact cognition that you got to make sure you tune up, because everything on this list is treatable. So treat it as best you can. So are there medications that actively improve cognition and memory? Sort of. I wish we had better. There were a couple of medications that were originally developed for people with Alzheimer's disease. that, as it turns out, have now been approved for people with Parkinson's disease. And I'll tell you, they actually work better in people with Parkinson's disease than they originally did with people with Alzheimer's disease. I probably prescribe these more than my colleagues who treat only patients with Alzheimer's dementia. The class of medication are called cholinesterase inhibitors. That's the class of the medication. These are the names. The ones at the beginning are their generic name, and in parentheses, that is the trade name that are used. The major side effect is some GI upset and diarrhea, and that's the major limiting factor in people with Alzheimer's disease. Interestingly, the first study that was done in people with Parkinson's disease, the group of patients who were on the treatment, on the drug, had a statistically significant reduction in constipation compared to the sugar pill. So this is not as much of a problem. And I think that's part of why it's more effective in Parkinson's, because we can just prescribe it better, because patients actually, sometimes it actually helps their constipation as well. I have had at least two patients who flipped from constipation to diarrhea with one of these medications. So it can happen, and it can be really bad. So if that ever happens, just tell your doctor, stop the medication. It completely goes away. But this is these donepezil, which is called Aricept, rivastigmine, which is called Exelon, which comes in both a pill form and a patch form. Galantamine is very rarely used in the US. It's more common in Europe, but it is available. It is out there. It's twice daily, and that's why people don't like it, because Aricept comes in a once daily form, and Exelon patch is a once daily form, so it's just preferred. The other class of medication is something that's called Namenda or memantine. This is a different class of medication, an NMDA receptor antagonist. The studies in Parkinson's have been so-so. You know, there hasn't been like a really convincing study that this definitely works in people with Parkinson's disease or people with dementia with Lewy bodies. But I will tell you, I've had some patients who have come back and been like, yep, I definitely feel a little bit clearer. So I try it, but it's not as clear that it definitely works. It doesn't have the GI side effects. So if I have someone who can't tolerate one of the cholinesterase inhibitors, I'll try the NMDA receptor antagonist Namenda. But you can actually use them together. So you could use one of these and one of these together. You would never do two of the cholinesterase inhibitors, because it's just a different version of the same thing. So this is what we have. This is what's FDA approved. This is what's available. They're okay. They're not great, but they're worth trying. And I try them pretty regularly in my clinic. What about exercise? We hear so much about exercise in Parkinson's disease. Well, it turns out in animal studies of both Alzheimer's disease and Parkinson's disease, mice who are physically active have less pathology in their brains than those that are sedentary. So these are mice that are made to have Parkinson's or Alzheimer's. Animals don't actually naturally get either of these conditions, so we manipulate the proteins to make it happen. But the ones that run on the treadmill their whole lives actually have protection of those dopamine producing neurons and other neurons in their brains. Now, we can't exactly replicate that experiment in human beings, but it does seem like this is good for cognition. But what kind of exercise? Well, like everything in Parkinson's, when it comes to exercise, the big picture answer is it is better to exercise than to not exercise. Anything we study is better than not exercising. The exercise bike, better than not exercising. Tai Chi, better than not exercising. Dance for Parkinson's, better than not exercising. Rock steady boxing, better than not exercising. So the most important thing is that you do something that is safe for you and something that you're going to enjoy and stick with. And that's actually really critical when it comes to exercise. So I'm a swimmer. I love swimming. I've been swimming my whole life since I was 4 years old. I got up this morning at 6 o'clock in the morning to make the 6:30 a.m. Saturday morning swim practice. That's what I do on the weekdays. I get up at 5:30 to swim at the 6 a.m. practice. It's one of those things. I can get myself out of bed into a pool at 5:30 in the morning, no problems. You could not pay me enough money to run. I do not run. I can't run. I tried it for a while. I did a couple 5Ks and 10Ks. It is the most miserable experience for me. I'm a swimmer. I'm not a runner. So if I need to exercise, it's going to be swimming, period. End of story. I really don't think I could do it. I actually think I can swim further than I can walk. I'm one of those people. We all have our preferences and we all have the things we're not good at. So the most important thing about exercise, pick something you enjoy that you are going to stick with. Don't get overly wowed by the what's in fad and that kind of thing. Some people like dance, some people like boxing, some people like Tai Chi, some people like exercise bikes. The most important thing is to do something you're going to stick with, because that's the critical part. And yes, we have seen some studies that show that staying physically active is actually not just good physically, but also good for your cognition in terms of Parkinson's. So stay physically active. What about dopamine? I brought this up at the very beginning. So it's a little unclear how much dopamine replacement medications, either dopamine agonists or levodopa, do they hurt? Do they help? They probably are neutral. We don't really see, it does help people sometimes perform better on tests, but that's because they can move better and they can function better and they don't feel trapped in their body. So we always tell people to do their cognitive tests when the medication's working, but they probably don't make much of it. They don't hurt cognition at all. We haven't seen proof that it actually injures your cognition at all. So we think dopamine is safe for cognition. Unfortunately, it just doesn't help it tremendously. I will say the one thing though, is that patients who have hallucinations, certain dopamine replacement can make those hallucinations worse. And so if someone's having a lot of really bad visual spatial function and terrible hallucinations specifically, that is worth talking to your doctor about, because there's a balance between what's good for your movement and what's making the hallucinations worse. And so this is a really important balance to consider in someone who is struggling with those hallucinations. But there are some things other things we can do to help with the hallucinations too. All right, so what about cognitive, like brain games, cognitive tests? I get asked about this all the time. This is just one example of one that's available online. There are lots of different ones. You know, there's been a lot of mixed reports. I think, again, similar to exercise, staying cognitively active is really important. I don't think which thing you do matters. Generally speaking, you get better at the test that you take all the time, right? And so if you're really good at Sudoku, you keep doing Sudoku, you get better at that. If you like doing crossword puzzles, keep doing that. If you like doing these brain games, you will get better at the brain games. Whether it's going to help you balance your checkbook better at the end of the month, there's less evidence to support that. But I would say staying cognitively active in things that you enjoy are just as important as staying physically active in things that you enjoy. But there's no one type of brain training that has convincingly been shown to definitely improve cognition in people with Parkinson's. So just stay active and pick one that you like doing, because that's what's important. So I'll just sort of finish up with thinking about, the future. As I mentioned, this is a hard area to study, and it's been quite neglected for many decades. We've gotten a lot more attention recently, but it's something that there's a lot more interest in doing. And I know you guys live pretty far away from Stanford and UCSF, but I just wanted to tell you all that if you are interested, there are research studies that are going on that focus on cognitive changes at both UCSF and at Stanford that really are focusing on these different types of cognitive changes. And research studies are really hard to recruit for. They really got a hard hit, obviously, during the pandemic. But even before that, fewer than 10% of all people with Parkinson's disease ever take part in any type of research, despite the overwhelming interest in scientists to speed up with their breakthroughs. We can't really do this type of research in mice. They don't have real Parkinson's disease, and they don't have the type of cognitive function that I've been talking about here. And so we really have to understand it in the context of real people and humans. So there are a bunch of different things that you can consider, and I'm happy to send my slides to Mark so that you guys can all have access to them. There are just a couple of studies that we're doing at Stanford. This is our Healthy Brain Aging study that's sponsored by the NIH, that's focused on cognition. It is annual. It's a big commitment, especially if you're coming from far away. But we are hoping to get back to being able to provide people with some transportation reimbursement if folks are interested in coming from further away, and even putting people up in a hotel room the night before if they want to participate. The UCSF program is recruiting patients for their PPMI biomarker study. This also has a big cognitive focus. Again, this is an annual assessment. This is for newly diagnosed people who are not yet on their medications. So this is the clinicaltrials.gov number for the UCSF colleagues down there. This is a clinical trial also being done at UCSF for motor fluctuations. So as we said, there's a link between cognitive and motor symptoms. And so we think about how much motor fluctuations influence cognitive. And this is an important one to consider if you're having a lot of motor fluctuations that might be impacting your day-to-day life. This is a fascinating study also from my colleagues down at UCSF. This one is 100% remote. So one of the first 100% remote clinical trials in Parkinson's disease. And it's looking at a medication that could prevent fractures from falls. So it doesn't prevent falls, but it's supposed to reduce the risk of fractures from falls. And it's 100% remote. It's a one-time dose of a medication, either the medication or the placebo. And then there's a study nurse who actually comes to your home for a short exam and then checks on you every couple of months. So I'm really excited about the idea of a fully remote clinical trial as a way to try to get better medications to patients without the burden of having to come into these university medical centers for research. So that one's super exciting for me. And then if you ever want to know, oops, wrong direction. If you ever want to know what else is going on, this is the clinical trials page for Stanford, and this is the clinical trials page for UCSF. I think both centers do a pretty good job of keeping their website up to date on the things that they're recruiting for. So you can always check in there to see if there's anything going on that you might be interested in, and then sending a message to the study coordinators to find out what's going on. All right, so I'm gonna hopefully spend the rest of the time answering any questions. This is me getting my booster a few weeks ago. So just wanted to give a plug for people getting vaccinated. As I said, infection, generally speaking, is one of the worst things for someone with Parkinson's disease, whether it's the flu, the cold, and especially if it's COVID. And so I just want to encourage anybody to get their boosters. I will say I've not had anyone's Parkinson's disease worsen directly due to vaccination. And that has been a pretty universal feedback that I've gotten from my colleagues across the world, in fact. And so want to definitely encourage people to do that so you can protect yourself, protect your loved ones, and protect your cognition. So I'm going to leave share, and I see at least one question in the chat, and I'm going to start with that one, and then if there are other folks as well, we will go with those. Okay. When do I consider using medications to meet mild cognitive impairment, and what are the side effects? It's a great question. So when do you think about starting one of these medications? People with Parkinson's take a lot of medications, and I always really think hard about adding something new, because between the motor symptoms and the constipation and the insomnia and the urinary frequency, boy, they really start to add up. And then you've got other things, heart medications and stuff like that. And, we always have to really think about side effects. And so, like everything in Parkinson's disease, one of the rules that I use is that just because we're aware of a symptom doesn't mean we have to treat it. It depends on how much that symptom is bothering this specific person and their ability to do the activities that matter most to them. And that answer is going to be different for everybody. You know, if I think about in the context of tremor, somebody who is, you know, retired and has tremor in their non-dominant hand, and it goes away every time they try to use something like eating or, you know, driving, it doesn't really come out. It's only there at rest. Doesn't really bother them. Maybe we don't treat that tremor, right? It's not interfering with their day-to-day activities. It doesn't bother them. Yeah, it's there. I can rate it on my scale, but do I need to treat it? Not unless it's bothering the person. Whereas someone else, you know, maybe it's in their dominant hand, and every time they go to do something, to type on the computer or click on a mouse, it's really, really interfering, or it's keeping them from doing their job or cooking meals. That's a different thing. And so the severity of the symptom isn't as important to me as how it's impacting that one person's personal day-to-day activities. And so, so that's how I think about it. So how much is the cognitive impairment impacting your ability to do things? Can you get just as much improvement by maybe keeping better lists or having an organized calendar or having occasional reminders? If there's a non-medication therapy for something, it's always better to go with the non-medication first because less side effects. Okay, is there much sharing results of clinical trial findings periodically with patients during the trial? Yeah, this is a great question. So in a observational clinical trial where we're not testing a drug, we're just gathering information on people, we are trying to do a better job, we meaning the scientific community, of sharing more information with patients, because I have gotten this feedback regularly over the last decade that people want to know what happens, right? You guys come in, you do these brain scans, you do these brain tests, you get blood tests. What the heck happens to all that? So I think it's really important. And I think we as doctors have kind of not been as good as we should be on this. We at Stanford have started to do two things for anyone who's involved in our Healthy Brain Aging project. So once a year, we do our annual patient appreciation symposium. It was last week. And we try to give, actually, if some of the researchers who use the research data give results to patients and talk about what the heck we did with their blood samples or their lumbar puncture samples or their brain tests. We also, my lab does a newsletter every year where we write out some of the results of things. Folks who are in that PPMI study, the Michael J. Fox Foundation funded PPMI study that's happening at UCSF, they also have regular webinars where they have people report back research results. So I think those studies are doing better. The ones where there's an intervention, where there's a drug that's being tried, those you're actually not allowed to show the results until they are publicly available, until it's unblinded, right? Because that's part of the whole deal, is that you don't know if you got the treatment or the placebo, and you have to compare the difference. And so everyone in the world finds out at the exact same time what happened. There were a couple of early phase 2 clinical trials in Parkinson's that were just announced last week. Again, early studies, like 40 patients in the treatment group, 40 patients in the placebo group, very small early results, but everybody finds out at the same time with those. So it's a little harder to get feedback, but they do actually give those results, but not as frequently. Okay. Is there a reason to stop selegiline before surgery? Deep brain, whether it's deep brain stimulation surgery or other surgeries, it depends on if you have to come off all of your medications for the surgery. So for sometimes people who get deep brain stimulation, we have them stop actually all their medications the day before the surgery. It depends on the way the DBS is being done. It depends on, every patient is different, what medications have to stop for what things. So that's that's a surgery to surgery, patient to patient specific thing that you should always make clear from your surgeon or your doctor what medications to stop before surgery, because it depends on the surgery and what they want for that. Similarly, the next question, best med or treatment for tremor, it depends. Every patient is different, it turns out. And generally speaking, while replacing dopamine is the best thing broadly for slowness, stiffness, and tremor, different patients have different responses to different medications. And so there's not just a one and done with tremor and like, this is the one for everybody. There are other things that can be tried, and it just depends on the person and the side effect profile. So this makes Parkinson's really, really tough because there is no formula. You have this symptom, you take this drug. Every patient is a little bit different in which medication. So it just depends on the person. All right. So my background, this is the School of Medicine here, Stanford School of Medicine building. Which is one of, I think, the prettier buildings on campus. Plus, I like the palm tree. So that's why I use this one as my background. So thank you very much. Okay, so somebody asked here, is there something that can help visual spatial function beyond exercise? This is a really, really great question. So visual spatial function is one of the harder pieces of cognition to help with, and it depends on how impaired or how difficult the visual spatial function is. If it is bad enough that it's causing hallucinations, there are some medications that can directly help with hallucinations specifically. There's one that is FDA approved for hallucinations. The name of it is pimavanserin. It's okay. It's not fantastic. I use it, but it's okay. It helps a little bit. We don't have a better medication with just non-hallucination visual spatial function. The biggest thing that I've really found that helps with it is actually, interestingly, physical therapy, because one of the things the therapists teach is how to better judge where your body is in relation to the world around you. So they can teach you tricks for specifically, let's say somebody's having difficulty with visual spatial function, they keep trying to sit down before they get to the chair. That's one I hear about really commonly. Physical therapists are really good at helping people to use tactile function, so use their hands. So make sure you walk to the chair and touch it before you pivot and sit down in it, right? So make sure if you're close enough to touch it, then you're close enough to sit in it, and to use kind of your hand as a guide so you get additional input, because your eyes aren't giving you the full story. Your eyes are telling you things are closer than they actually are, or your distance from you to them is different. So you have to use other senses, and the best sense is the sense of touch. And so use touching something to try to judge where it is in relation to you is a better one to use. And so I have actually found physical therapists as well as occupational therapists to be very helpful for visual spatial function. And yeah, somebody mentioned here that the Kaiser occupational therapist suggested being careful of excessive furniture or tables with sharp edges. If someone's having a hard time navigating around their house because of the visual spatial function, then making some adjustments to certain things can really help tremendously. Making sure there aren't excessive things on the floor that they have to navigate around. And that can be very helpful. Again, occupational therapists are really, really good at this kind of thing, observing what's going on and identifying little changes that can be made to help with things like visual spatial function. So I would rely heavily on your PT and OT in this type of situation. It's a great suggestion. Thank you for Thank you for saying that. I love my occupational therapists. They do really, really incredible work. Very helpful. Other questions? Give you guys a moment to think as you're sitting there. I know I threw a lot of information at you. As I said, I'm more than happy to go ahead and I'll distribute my my slide set to Mark, and he can pass it around to the group if any of that information is helpful. I do see a hand that's raised. Please, can you unmute yourself?
I'm curious about the glove that Dr. Tass is working with in Stanford.
Yeah, great question. So for those of you who don't know, there's a little bit of a, there was some publicity, I think a few weeks ago out about this. So one of our really wonderful electrical engineers here has been working over the last decade now in trying to use the peripheral nervous system to regulate or modulate the brain. So the idea is that your movement and your sensation are all part of this loop to the brain, right? So I'm sitting here drinking my water that's behind my screen while we're sitting here talking, right? And so I don't actually have to be looking at where my glass is. I know where it is because I can feel it in my hand. And that's giving information to my brain, which then tells my muscles in my arm how to bring my glass up to my mouth, right? So that's the sensory motor loop circuit that's happening. So Dr. Tass's idea is to use that sensory information to re-regulate different parts of the brain. And so because we know the sensory and the motor are connected through these really important circuits in the brain. And so he's been working on this glove that gives very specific kind of tactile information back. So basically different sensations to the hand with the idea of trying to regulate tremor based on the information, the sensory information to the hand. And he's been working on this for a really long time. There have been some very preliminary studies that were very promising, but as we know with anything, unless there's a really good control placebo group, it's very hard to draw any conclusions. I've been parts of lots and lots of clinical trials in the last decade, and the placebo effect, particularly in people with Parkinson's, is very strong. We don't fully understand it, but what we have to figure out is this actually something that's happening from the glove, or is this just part of being in a clinical trial? And I'll tell you just from my personal experience, you know, I was part of a clinical trial once, and there's this one patient who just, oh my gosh, they just did so much better. I was totally convinced this therapy was just incredible and totally working. They were part of the study for, you know, almost 2 full years. And when we got the unblinded results, where we find out who's in what group, that person was completely in the placebo group. They had gotten no treatment whatsoever other than coming to Stanford every 3 months and seeing me and my wonderful research team. Incredible placebo effect. And so it's really very, it's something that, you know, again, there's nothing quite like seeing to believe, that you really have to have the data of a well-controlled study. So we're doing that now, and I'm really excited about it. I don't know all the details. It is on our website. I made sure the doctor who's running it, I'm one of the blinded raters. So anyone who's in the study, they videotape the exams, and I grade them offline, sitting here at my computer. I don't know whether someone's had the glove or not had the glove the week before, and I basically do all the ratings. So I'm totally blinded to what happens to the people in the study, and I just give my motor ratings, and then they'll see if my motor ratings are better in the people who had the glove than not. So this is one of our ways of trying to have a better placebo. It is really hard to do a well placebo controlled trial. I'll tell you that right now. So one of the ways we do it is we do the videotaped exams, and then you have somebody like me who's not involved at all, but who does all the ratings offline. So we're trying to do that. So I'm hopeful. We'll see. I don't know what to expect. I'm cautiously optimistic. So, okay. Somebody had asked about memantine. So it works through this NMDA system, which is one of the neurochemicals in the brain. To be honest, we don't 100% know how it works in people with Parkinson's, because like the other medications, it was actually first developed for Alzheimer's disease. But we know that this receptor, this NMDA receptor, can be overactive in people with Parkinson's. And so blocking it, that's what an antagonist does, it blocks this receptor, can help to enhance cognition and memory. I'll tell you, it's again, the studies in Parkinson's have been very plus minus. One of the things that like some of my patients have said is they felt like their verbal fluency was a little bit better. They had a little bit easier time engaging in conversations in real time, those kinds of things, better attention. But it's been really plus minus, that you know, some people tell me it does absolutely nothing for them. So I try it and I see if that person gets benefit, you know, or not. How long would it be effective? Again, it's been super variable. I've had some people where it's been helpful for, you know, a couple of months. Other people have been on it for 2 or 3 years and feel like they're still getting benefits. So it's definitely a trial and error type medication. There's just not a consistent response. So we try it, and then if people feel like it's not doing anything, I stop it. And, you know, there's no reason to be on a medication if you don't think it's really doing something super, super helpful. So, all right, our Stanford physicians who specialize on PD patients whose symptoms are predominantly cognitive. So, you know, one of the advantages of being one of the research institutes that has focused so much on cognition is that all of our movement disorder specialists are very well trained on the non-motor symptoms. And we actually talk about this quite regularly. One of the other big advantages of Stanford is that our behavioral neurology group, the folks who primarily take care of people with Alzheimer's disease, and our movement disorders group, who primarily take care of Parkinson's, we work very closely together. We have meetings together. We do teaching together. We teach our trainees together. And so we really function as one very interactive group. And so all of our Parkinson's specialists, any of them at Stanford, are very good at understanding and treating the cognitive symptoms. And I'd say over half of the group is very involved in our cognitive research studies. So they're part of that as well. So it's a great group that I think is very well-rounded in both the motor and the non-motor symptoms in Parkinson's. All right, I think I got most of the questions. Mark, do you see any that I missed there? I think I got all of them. I'm just swinging through.
Just how wonderful your talk's been.
Kathleen, thank you so much from the Parkinson Support Group of Sonoma County. Your presentation was so comprehensive and really gave us a broad spectrum of what memory, movement disorders, and cognitive functioning is in Parkinson's. It was an excellent presentation. And I want you to know we will have it recorded and on our website so that
Perfect.
you can come back and resource this talk. Thank you so much for coming.
Absolutely. It's a pleasure to be here today. I just want to say, you know, thank you to all of you for staying engaged in the Parkinson support group community during all of this virtual stuff. I think this has been, it's been hard to stay engaged with things like this over virtual. And I think that it's so important for people. You know, I didn't talk about social engagement. I focused on the physical and the cognitive. I'd say the third pillar to that is the social piece and staying socially engaged. And that's been hard for all of us during this time. So just congratulations to all of you for at least virtually maintaining the social engagement. And I just encourage all of you to really do as much as you possibly can from that perspective, because I think that helps a lot for all of us. So, oh, and I do see one more hand raised before we log off. Can you unmute yourself?
Yeah, I just threw in a question at the end,
Oh, there we go.
wondering if there's any researchers that are specializing in PSP.
Oh, excellent. Yes. So, so again, I think we have a very comprehensive group on PSP, which is progressive supranuclear palsy. It's one of those Parkinson's like syndromes. We do actually have one physician in our group who is the director of our Cure PSP group. So we're one of the many centers who has a Cure PSP chapter. It's basically just part of the national organization that's trying to, understand PSP as best as we can. We don't have a cure yet, but that's their goal. And so that is, I will throw her picture and name up here. Oops, wrong direction. We'll go back to the top. And there we go.
It's in your mouth, Jerry.
And I will share real quick. Okay, so that is this wonderful physician right here, Dr. Leila Montessori Corsari. She is our director of our Cure PSP chapter, and so she probably sees the most PSP patients in our group. UCSF also has a Cure PSP chapter. I don't know exactly who their director is, but I know that they also have a chapter there. And so she probably sees the most PSP in our group. But we all do. We all see it's part of the breadth of Parkinson's and Parkinson's-like syndromes. So I know it's a hard last name to pronounce, but Layla is her first name, and her bio is on our website. So, and you'll see it in the slides that get shared. So, and yes, ballroom dance is good for physical, mental, and social. I completely agree. I actually think the rock steady boxing as well is also really, really great for the physical, mental, and social as well. So anything that's engaging you both mentally and physically, and you're doing with other people, gets all three of those pillars. So I strongly encourage them. So, all right.
Thank you.
Excellent. Lovely to spend Saturday with all of you. I hope you all enjoy your weekend, and have a great weekend. Thank you all so much.
Thank you. Very good.
Thank you so much.